Great. Well, let's get started because we do have, I know we have a number of people coming on. We scheduled this particularly around Dr. Forester and Dr. Palumbo's schedules, and Dr. Forester had literally 1 hour in the sort of a 6-month time period that he was able to do this. So 3 o'clock is not our normal time to do these sessions, but really, really excited and really important to hear from these two stunning doctors in this area, in this field. I have had the great pleasure of knowing both of them for some time, and I'm going to let them do some of their own introductions as well. But Brent, I have actually known for 38 years. We went to school at Dartmouth together, and we were both the class of '88. And he has been a preeminent doctor in this entire field for his whole career. In fact, McLean Hospital and Mass General Brigham have had him for the last 25 years. And he headed up not only was the chief of the geriatric psychiatry division, but also director of dementia care, behavioral health, mental health. This is his deep, deep expertise. For those of you also, many on the call who I know, he, on a personal note, as life would have it, also took me through the whole process as my Scott was diagnosed with early Alzheimer's, and it was Brent and his team in the middle of COVID and throughout actually a 10-year period culminating with COVID, where we were making all our most difficult decisions about car keys and was he safe in the home and how to do this, how to navigate. And Brent was also my North Star. So we certainly have been living this topic in every way that you can and can't imagine. And he has now taken a brand new position at Tufts, running everything as far as I can tell. So he can tell you more about that, both in the medical school and the hospital. And very, very exciting. He starts June 1st. Dr. Palumbo and I have had the incredible pleasure of working together at BioV, where we do have a promising molecule for both Alzheimer's and Parkinson's that he will talk a bit about in the context of the overall industry. But he has an incredibly esteemed career that includes Johnson & Johnson as head of psychiatry, clinical R&D, and neuroscience, and formerly chief medical officer at Zenerba. Actually had one of the first molecules approved in the treatment of autism. And just an incredibly esteemed and international career in doing that. He led a team in US, Japan, EU, and he is now the chief medical officer at BioV. So we have two incredible speakers, and I recommend maybe in your settings to put the speaker view on when they're talking. They are going to share our hour, and we are going to spend the last really save 10 or 15 minutes for questions, because I know that even though I've known these men all my life, I always have so many questions for them. And I'm sure everybody on this call does. This is a topic that is so intensely important and personal to all of us. And also that everyone on this call is deeply involved in some way. So I am enormously, enormously grateful for their time. So thank you. Thank you both so very much. I'm going to start with Joe, Dr. Palumbo, although he'll want me to call him Joe. And I'm really hoping, Joe, that you can walk us through what is happening in the marketplace right now. People are, for the first time, really in 100 years, seeing, we haven't had any breakthroughs. Nothing has been happening. And all of a sudden, all of us who work on this day in, day out, are in a very, very hopeful moment as far as the science is concerned. And so I know everybody would like to hear just a little bit about what is out there, if you could unpeel it for us and just give us a roadmap for what's happening right now with the science.
Oh, absolutely. Did you ever think we'd be here? Did
No.
you ever think we'd be in this place where we now have several molecules that have the promise and actually have documented we can slow the disease. Did you ever think we'd be here? It's amazing. So I'm a neuroscientist, and I've been at the bench and in the clinic, and later on moved into industry to work with laboratories, work with people. And first of all, you have to thank the thousands and thousands of families that have been involved and engaged and hoped and prayed that we'd be here, that we're finally making inroads. And at the end of this, I hope we're going to ask Dr. Forester where he imagines we're going to go next.
You get to ask him questions too.
You know what? I think I will, because he sees it across the board in every possible way. And while I've left the bedside, Dr. Forester is not only leading at the bedside, he's leading many physicians in their education. So a tremendous day where it wasn't very long ago, really only about a year ago or so, where we had symptomatic therapies that had been around for a couple of decades. And while very, very helpful, their effects would wane over time. And I remember when the first drugs came out, and we were thrilled. We had something. And now we have more than something. And I think one of the greatest things about these new molecules that work to treat amyloid for the most part, right? And in reducing amyloid load, we can see improvements in cognition and thinking, right, relative to placebo treatment. The hope that comes with that is the biggest deal. And for all of us who work in the field, this incredible sense that there's a little indication, right? That the hard work of all these families and scientists and the investment has proven we can move things. And not move them in a small way, move them in a large way, move them so that we can change progression by about a third. And that's no small thing. So what's going on in the marketplace? We have a first generation of drugs. We have the beginning of a second generation of drugs to modify disease by looking at a culmination of decades of work by the scientific community, looking at what happens in the brain, picking a target, never giving up, and being able to present the data as quickly as possible to an eager community, and having our FDA and other global health authorities looking at that data and also getting excited. So it's a great day.
Can you tell us a little bit, and Brent, please chime in on the drugs that have been approved, and also talk a little bit about inflammation and its role as you see it, having done some deep work in that area in both Alzheimer's, Parkinson's, and other neurodegenerative diseases. Can you address that?
So I guess I'll start. So the new drugs, and I'll let Dr. Forester describe them in depth, because I think he knows them very, very well. The newer drugs reduce the burden of a certain protein that interrupts function in the brain. They have an effect to hurt the brain in terms of creating inflammation. Their initial activity in the brain may be potentially there to protect the brain against insult, but over time, these deposits impact the way that the brain functions in very considerable ways. That we certainly, in our work, have been working on the level of inflammation. The hypothesis is that when the brain is inflamed, when certain cells in the brain, part of the immune system, become angry, perhaps when they shouldn't be angry, they damage tissue. Damaging that tissue results in a cascade where more tissue gets damaged. And it is in that inflammatory soup in which other proteins, including tau and amyloid, can functionally do more damage. So, we're hoping, as many other companies are hoping, to be able to treat some of these causes, along with genetics, along with looking at genetic markers and changes that occur with aging. But none of this occurs outside the context of these new approvals, drugs that will soon be approved. And again, we're motivated certainly by need, but we are very much encouraged by these newer findings and these newer wins for everyone.
So, Dr. Forester, as kind of a nice lead in, I think that, one of the things in this hopeful moment, and I know you're going to address this in, everyone should have Brent Forester's book, by the way. We'll send out a link. It's been one of my Bibles, but there's I know 3 big things you're going to address for us today, but part of, going from the diagnostics and the science to the caregiver burden and what caregivers can do, and then some of your thoughts around the way to lead the best brain healthy life. But as we start the conversation where Dr. Palumbo was just talking about the current science, can you give us a little bit of your thoughts on acanumab and the drugs that have been currently, everyone's seeing the news out there and is trying to peel apart what is actually happening right now, and then maybe we can get into the first part of what you're going to talk about with the diagnostics and the current science, because I really think people, one of our big hopes with this series is that people don't know where to start, don't know when to come in, don't know what to do, and most people don't even know that there is some hope and some solutions. So maybe you could start off by picking it up where Dr. Palumbo left off.
Sure. Well, thanks, Sarah, for inviting me, and for all of you for being here today. So usually I have a sense of the knowledge base of the audience before starting, and I'm getting a sense this is a very knowledgeable group of people looking around the room and hearing some of your background. So I have some slides that I do want to go through, but maybe to pick up where Joe left off. For those of you who don't know, we've had about a decade or 12 years of trials that have really tried to target the underlying pathophysiology of Alzheimer's disease, amyloid plaques and neurofibrillary tangles. And actually the tangle research is way newer than the amyloid research. But until recently, all of the trials with the amyloid-based therapies that try to remove plaque from the brain or prevent it from being deposited in the first place have been systematic failures until recently. And there are a lot of theories about why those treatments may have failed to demonstrate clinical benefit. But one major theoretical reason is that the interventions were occurring way too late in the cascade of events. And normally when I give this talk, I start with this part of it in the middle or towards the end and not in the beginning, but to catch up quickly, in order to really make an impact on the disease process, you got to start early. You got to get people when they have the very earliest stages of disease in their brain. And we know that amyloid plaque deposition probably occurs 2 decades before symptoms begin. 2 decades. So that if somebody's diagnosed at the age of 75 with very early stage Alzheimer's disease, they probably had amyloid plaque built up in their brain since their mid-50s. And there are no symptoms, and we don't have biomarkers yet that can easily diagnose that at that stage. So one of our biggest challenges in trying to find the right people to intervene with these new treatments is going to be to how do we actually make these diagnoses earlier? And that's one of the biggest problems we have right now in clinical medicine, is that Alzheimer's disease is only diagnosed in about half the people with the illness, and about half the people are not diagnosed until they're already in the moderate stage of illness when they can't drive or pay their bills. And in order for any of these therapies to be effective in slowing disease progression, as Joe was mentioning, we have to get people in the mild cognitive impairment or the mild dementia stages, when it may not be apparent through casual conversation or an interaction with a primary care physician that there's an issue. And we also have to remember that these these treatments are only going to be effective for people with the Alzheimer's type of dementia, which accounts for about 2/3 of all dementias. So there are a lot of other dementias like frontotemporal dementia, Lewy body dementia, et cetera, that really will not be, those individuals won't be candidates for these types of treatments either. And the other thing with these treatments, in terms of just the big picture perspective, is that they were studied in rarefied populations. I've been the principal investigator of all 3 compounds that are now either gone through accelerated approval or will be approved very soon. aducanumab, lecanemab, and donanemab. All three of those antibodies, our screen fail rate in getting people into these studies was nearly 80%. That means 8 out of 10 people that came in who looked like they might be candidates on paper, when we did all the biomarker testing, the concomitant medications, the other medical problems they had, 80% of these people did not meet criteria to be enrolled in the trials. So when you start to take the drugs that are now going to come on the market and give them to a larger population of people, there's the potential for risk that is yet unseen. So that's something that we're very concerned about. But the bottom line, as Joe was saying, is that these treatments, when used in the right population at the right time, seem to slow the decline in loss of cognition and functioning by, with lecanemab, about 27% compared to placebo at the end of 18 months. And with the newest drug that you saw the press release from Eli Lilly last Thursday morning, 35% change, drug versus placebo, at the end of their trial. So I'm happy in the Q&A to talk more about these treatments. There are side effects, of course, as well. When you are introducing an antibody to the brain that essentially is reducing plaque burden in the brain, there is an inflammatory response, and that leads to brain swelling and brain hemorrhaging. Luckily, most of those cases that were reported in the trials are asymptomatic. In other words, people have the evidence of it on imaging studies, on MRI, but there are no clinical symptoms such as motor function deficits or sensory function deficits or worsening cognition or gait disturbances, et cetera. So you wouldn't know it unless you looked at the MRI. But in some small percentage of people who have those side effects, they have not only neurological side effects, like I mentioned, but there have been reports of death as well from hemorrhage. So we have to be very careful when this is brought into clinical practice to have the right safeguards in place to make sure that we're monitoring for safety. Not to mention that these are expensive treatments, which we're not even sure that CMS will cover, although we think they will once they receive full clinical approval from the FDA. So there's a lot to talk about. We could spend the entire hour on these 3 new treatments and where the field is going, but I thought I would take a step back, perhaps, Sarah, and start from the beginning and then open it up for Q&A at the end.
I think that's really important, because I think one of the things that all of us recognize, not only with the staggering numbers that we're dealing with, but how underreported this disease is. My Scott would not have been in the numbers, as you know, because he refused for a very long time to come in and do something, get anything done, because the sense is there's nothing to be done. So why do I, first of all, how do I know that I have something, and how can I get a diagnosis? And then if I get a diagnosis, what can I even do about it? Is it worth my time? And so I hope very much as we dive into this, and the answer to that question of whether this is actually going to help the current patient or our kids, that I hope one of the things we all do is heavily and highly encourage people being involved in trials, because the only way we solve this is to have everyone participate, whether it is for themselves or for the next generation. We obviously must solve this this crisis. So please give us some windows into that, and how we can help our families and our all of our constituents get help.
Great. So you guys can see that okay?
Yes.
Right.
That's great.
Just in case you guys like history, the bottom picture in the middle is the building next to where I'm sitting right now at McLean Hospital. I moved here from the campus on the left, which was in Charlestown, actually in Somerville, Massachusetts, 1811, that was McLean Hospital. In 1895, I moved here to Belmont. And then we have this large corporate entity called Mass General Brigham, with its building here at Assembly Row in Somerville, not far from where McLean originally stood, which is pretty cool. Anyway, I've been at McLean, as Sarah mentioned, for about a quarter of a century. And it's great to see Rick and others on this call as well. I've had a lot of experience working in long-term care settings, especially in the assisted living memory care world, as a clinician, an educator, and also done research there. I've worked on inpatient settings, outpatient settings, you name it. And my passion really is really training the next generation, caring for patients and their families, and trying to find new treatments that are going to be more effective than we currently have. So I just want to go through again, for some of you may be expert in this and others may be newer to it all, but I want to go over the epidemiology and current imperative for understanding the sort of the epidemic of Alzheimer's disease and related disorders. I also want to introduce, some of you may not know about these models of dementia care that are currently not well funded by Medicare, but I think really are the holistic population-based approach that we need, and what we've been doing here at Mass General Brigham about it, and then I'll talk more about healthy brain aging. Every year in March, the Alzheimer's Association comes out with this amazing document called the, I got to edit this now, 2023, Facts and Figures. But basically 6.7 million Americans currently have Alzheimer's disease or other dementias. I already talked about the underdiagnosis problem and the delay in diagnosis problem, but there's this massive cost problem as well. And the costs of care in the United States today are about $345 billion a year. And that does not include nearly the same amount in unpaid caregiver time, which Sarah knows well and many others do as well. This is the only disease that I'm aware of in the top 10 causes of death, where the numbers are going up and not down. And the impact on caregivers is just tremendous, not just in their lost hours to work and the costs, but it's the emotional toll and it's the medical toll. And I've spent countless years educating caregivers that if they don't take care of themselves while they're caring for their loved ones, they may wind up dying before their loved ones do. And it sounds kind of harsh, but it's sadly true. And I've seen so many examples of it in my practice. The important message to take home is that diagnosing Alzheimer's disease is really relatively straightforward most of the time and can be done in primary care. And yet it's not. And the reason it's not is there's really no systematic education of physicians who have trained, those who have trained in the last few years are getting more education. But I know when I went to med school 30 plus years ago, we didn't get trained much in this. Even in my psychiatry residency program, I had very little introduction to Alzheimer's disease. It wasn't until I specialized in the area. So I think part of my job as a specialist and my colleagues is really to train the workforce of general practitioners, nurse practitioners, PAs, you name it, in order to provide comprehensive dementia care. So to me, the most important thing that anyone can do is get a good history. Is listen to the family members or the individual with the illness about the onset of illness, when it occurred, when the symptoms began, what the course has been like, how it's impacted their daily functioning and their social relationships. That to me is often the key thing in making the diagnosis. There are a lot of other testing we can do, but that's the most important thing. We look very carefully at medications that might be causing cognitive symptoms, even over-the-counter medications. We look at blood work, including thyroid function, vitamin B12, folate, vitamin D levels, and usual basic serum chemistries to see if there's anything medically going on that might be causing the problem. And then we have cognitive screening tools that are not widely utilized either in general medical settings, in part because there is no national recommendation to do systematic cognitive assessment. And there are a lot of reasons for that, but one of the reasons why is that there would be a lot of false positives and a lot of cause for alarm. And the therapeutic nihilists out there who say that why bother making the diagnosis if there's no definitive evidence that treatments work. Right. That's hugely problematic. Yes. And that's part of ageism. And I think it really inhibits accurate and timely diagnosis. It's also really important to screen for psychiatric illness, anxiety, depression, prior history of those problems, substance abuse, all can manifest with cognitive problems as someone gets older. And then there are times when you want to refer for further assessment, like imaging studies. Everyone, at least once, according to the American Academy of Neurology, should have at least one brain scan as part of the workup. A CT scan or an MRI will suffice, not to make a diagnosis, but to look for things that might be causing the problem in the first place. And then there are neuropsychologists who do detailed cognitive testing, especially in cases where people are presenting, Sarah, like your husband, early in life, younger than you would expect, where the presentation may be different, or where there may be a confusion between, is this Alzheimer's type dementia, is this Lewy body dementia, or something else? That's where neuropsych testing could be really helpful. And then we have some of these specialty testings. You're going to see a lot more with CSF, which is cerebrospinal fluid, a lumbar puncture or a spinal tap is the way to acquire the CSF. But that's where we can see these abnormal proteins of tau and amyloid in various ratios that can indicate or support a diagnosis. And they're not widely done in this country, except in clinical trials. But you're going to see more and more of this until we have serum biomarkers, blood-based biomarkers of brain pathology. And those are coming very, very soon in the next couple of years. The amyloid and tau PET scans, though, are the way to establish the neuropathological diagnosis of Alzheimer's disease and allow people to enter into studies and soon enough to enter into clinical treatment. Because Medicare doesn't pay for those scans, my prediction is that with the amyloid-based therapies that are coming on the market, until we have the blood-based biomarkers, the LP, the spinal tap, will be the way to make the pathological diagnosis. There are
Can I
many,
ask you one question in
yeah,
that one? I think,
anytime.
you
Yeah.
know, COVID really gave us, while we all had an extraordinary challenge, we also were given some new tools and gifts as a result. You and I both know the only way, since I couldn't physically, as a caregiver, get Scott to the doctor, that we were able to diagnose on Zoom. We were able to do these tests. I was able to put a computer in front of him. We were at least able to get baseline information that could not have been gotten before. And I'm just wondering, in both yours and Joe's assessment, we obviously know that we need to go into a doctor's office to get a lot of these things, but this early screening or some of those cognitive tests that we ended up doing with a computer, a pad, and Zoom, are we finding any ability to increase our diagnosis or accessibility through the technology? Is that still being used, or was that just in the emergency COVID moment?
I think it's transformed the way we do diagnosis, actually, Sarah. I know that even today, 3 years into this plus, although the public health emergency ends tomorrow, we are still doing the majority of our outpatient assessments in our clinic remotely.
Right.
That includes detailed neuropsychological testing, well beyond the basic one you see in front of you. Some of these tests can't be done for people who don't have access to technology. Some of them are challenging when you try to do it over the phone. But there is a test called I don't like this word, but they call it the blind MoCA. So if you don't have the ability to see, or you're doing this on a phone call, you can't name objects like you see here under naming, right? You can't name animals, and you can't draw, but you can do other things that don't require the visual parts of it. So, and the other thing that, is not really yet, I don't think, scaled effectively is digital neuropsych evaluation, because you can learn way more by doing a digital clock, the clock draw up here, than you can just doing a written clock, because you can assess all sorts of things using AI and other ways to really understand in way more depth with shorter interventions, frankly. So I think neuropsychological testing is going to move quickly into a digital intervention, some of which can be delivered remotely and some of which may have to be done.
Which I think will dramatically increase our numbers, particularly given mobility, transportation, cost, everything, and or willingness of the patient to come. So thank you.
So this is one screening tool. The reason I mention it is when I was in training, we used the mini mental status exam, and this one came later. But this test, which is a 30-point test, and it's translated into many languages, and it's very education and language sensitive as well. It assesses executive functioning, which is the top three things here, and visuospatial functioning. The trails A in the top left and the clock draw allows you to test someone's ability to organize and plan and shift set, things that are not at all easily assessed using the mini mental, but you can acquire data like that pretty quickly. Naming, memory, this is the registration of the 5 words. Then there's these attentional tasks, followed by a language abstraction and delayed recall. The nice thing also about this test is there are 2 different types of memory problems that we assess with this test. One is a memory storage problem, and the other is a memory retrieval problem. And there's a really clinically important difference between the 2. In somebody with Alzheimer's type dementia, they're unable to store new information no matter how many hints and cues you give them. So that down in the bottom here, category cues or multiple choice cues don't work essentially in somebody with Alzheimer's disease to get the information out of them because it was never stored in the first place. Whereas a memory retrieval problem is when you can't come up with the word until you're given a hint of, like, it was a type of a flower, or it was a color, or you give them a multiple choice cue. Those types of hints or reminders will point out a retrieval problem. And we tend to see retrieval memory problems in the vascular type of dementias, in the cognitive problems we see in people with depression, very different than the Alzheimer's type, which is really by definition an amnestic disorder of inability to learn new information. Okay. I talked about this earlier, but just as we start talking about when to intervene and how to intervene, the three stages of the pathology of Alzheimer's, we call preclinical, MCI, and dementia. And if you look at sort of the change in cognitive functioning over a period of years, the dotted line is the illness, and the black line there is just normal aging. So with normal aging, we see a decline, but the slope is way less steep. We're going to talk more about this, but essentially, very basically, preclinical means you've got amyloid plaque and or tau pathology in your brain, but you have no symptoms of illness, no memory loss, no functional deficits whatsoever. At some point, there's enough neurodegeneration in the brain that you develop the symptoms of the illness, and the first prodromal stage is called mild cognitive impairment, or in the new Diagnostic Manual in Psychiatry, mild neurocognitive disorder, which is a mouthful. And that essentially is cognitive decline with normal daily functioning. And then dementia adds functional impairment to the cognitive decline. These are syndromes. These are not diseases. They're caused by multiple types of diseases, one of which happens to be Alzheimer's type of dementia. And if you look at, I don't know if I have it in here, but if you look at a pie chart of all the types of dementias, Alzheimer's accounts for about 2/3 of them. Now, what's really important about this illness is that it's not just about cognition. It's about functioning, and it's also about behavior. And if you ask Sarah or any other caregiver, you will find out that it's the agitation and the aggression and the depression and the paranoia. That's what drives the burden of this disease, both for the people with the illness, because it enhances morbidity and mortality, but also the caregiver. This is why individuals with dementia wind up in hospitals and in long-term care settings. So this is usually what is the final straw that breaks the camel's back of the family's ability to cope. And these are treatable problems, despite the fact that as of today, the FDA is yet to approve a single drug for the treatment of any behavioral symptom of dementia, although one of the drugs will be reviewed today by the FDA. Today is actually their date. So these are common, almost universally common throughout all types of dementias. They include a whole host of symptoms we see in a range of psychiatric conditions. And they may be due to underlying brain changes. They could be due to other medical problems, or they may be related to what's going on in the environment. And it's our job as clinicians, with the help of families, to understand what's driving these behaviors in the first place, because without knowing the cause, you can't come up with a treatment. And as I mentioned,
I one of the things I want to just stop in the conversation right there, because however we're coming at this conversation today, and I know we have leaders in senior living, we've got senior medical providers, we have strategy officers in major companies who are trying to look at this. No matter how many books we've read, how much science we know, when it actually comes to you and your family, the overwhelming both guilt and ability to have the right answer as to what do I do when that's best both for the person with the disease and the other people in the house. And I think one of the things that you talked to me about really early is building a team, trying to have a team, because you're not always able to make those good decisions on your own, no matter how much you know. I had read every book, I knew all the science, and I still felt completely incapable of making the right decisions at the right times in those big moments, like taking away the car keys. That is a devastating thing for the person you do it to, right? When are you not safe, or the person themselves not safe in the house? And you have a whole strategy around this. And I think this is the kind of thing, as we're trying to get information out there, to talk about that for a moment, that caregiver piece of it, because these pieces are very hard to control, particularly for someone who hasn't gotten medicated yet. The hallucinations and the depression and those pieces. Can you talk a little bit about your strategy for people and what we can get out to families on that?
Yeah, I think this slide kind of goes into it. I mean, this is the clinical approach strategy, but in terms of the families, I think it's really important to, and Sarah, you mentioned this in terms of Scott, which is, not willing to be diagnosed or not willing to be treated, but at some point the family, and often it's the spouse or it's the adult child, has to step in and make decisions for somebody else. And that includes getting people into care. And you can't, as a family member, and now, unfortunately, I'm experiencing this firsthand in my own parents. They're both having issues related to psychiatric and cognitive changes. And I might as well be a plumber or a carpenter. I mean, it really doesn't matter that I have this medical knowledge, because when it's your own family, it's a whole different ball game.
Right.
And I'm the son. I'm not the expert here, but I want to create, like you were saying, a team of people who can help me navigate the journey. So it's not your responsibility to fix this stuff, but it's really helpful to be knowledgeable about it, how it impacts you, and make sure there are people who understand how to manage this clinically. And unfortunately, when families go out to look for help and they go first, say, to their PCP, they don't always get the answers they need. And that kind of gets into one thing I do want to talk about in a few minutes, just about how to re-engineer healthcare to try to address these issues. But these are the things a clinician would think about that a family member like Sarah would point out. And I'd want to know, well, like, what was going on when that aggressive outburst happened? Was it the time of the day? Was it the way you interacted with each other? Were they in pain? Were they sleep deprived? Was there any new medication involved? Have they been drinking alcohol? Are they withdrawing from sleeping medications? Do they have a history of bipolar disorder? I mean, these are the things that we look into. And I just want to have time to go through all this, but I want to just go through a couple things real quick. One is, Joe was talking about the new treatments, but to date, up until today, we've had 2 classes of drugs that have been on the market since 1993. The first class of drugs are called cholinesterase inhibitors, but they essentially inhibit an enzyme that breaks down acetylcholine. Acetylcholine is a neurotransmitter that we need for normal attention and memory. Those levels go down with aging, but they especially go down in Alzheimer's disease and in other dementias. So the 3 medicines that are now on the market are donepezil or Aricept, rivastigmine or Exelon, and galantamine. All those drugs do is symptomatic improvement. If you take the drug away, within 3 to 4 weeks, any benefit you've gained, drug placebo, goes away very quickly. In fact, some clinicians have seen, I have seen this multiple times, almost like a withdrawal effect, because you lose that benefit so quickly, because they're only symptomatically affecting the brain's biochemistry, not the underlying brain pathology of plaque-entangled disease. Now, there's another class of drugs, one other drug, it's called memantine or Namenda, and it essentially will modulate the chemical glutamate in the brain, so that there's too much of it's toxic, too little that you don't have enough normal attention and memory. So it does reduce it, but not too much, is essentially how it works. It's a partial antagonist at this NMDA receptor. So the standard of care today is to prescribe these 2 drugs together. First, a donepezil-like drug, and once they're stable for 2 to 3 months, to add memantine. People with frontotemporal dementia, which is more rare, maybe 5 to 7% of dementias, generally does not present with memory loss, presents with behavior change and executive functioning impairment, and usually earlier than Alzheimer's. Those patients do not benefit from these drugs, but almost every other dementia probably will have some benefit, for a period of time. And then we talked already about amyloid and tau and imaging, but I wanted to show you this picture on the next slide. It's not going. So the original aducanumab was the first of the 3 monoclonal antibodies that had some evidence of efficacy. This drug essentially is a monoclonal antibody that is infused once a month. This was from the original phase 1B trial, early stage development. Baseline amyloid plaque scans are on the left, and this basically shows red is amyloid, okay? And then a year later on the right, the placebo group, the 3, the 6, and the 10 milligrams per kilo group, and you see a complete removal of amyloid. The red is gone by 10 milligrams, and a lot of it's gone by 3 and 6 even. This shows the biomarker effect. Now, I guess the good news is that for all 3 antibodies that are now being studied in this phase of development, aducanumab, lecanemab, and donanemab, they all show this biomarker effect. And the first 2 drugs, aducanumab and lecanemab, were approved already by the FDA, not for their ability to change the clinical course of the disease, but because they're able to remove amyloid. What happened was, the aducanumab trials and all the problems there we can get into if you'd like, but suffice it to say, I've been following patients on aducanumab who've been on them for years, and some of them are remarkably clinically stable, even though the FDA did not give it full clinical approval because they stopped those studies early. They're doing a 3rd definitive trial, the results of which probably won't be out for a few years. Lecanemab is the one everyone's excited about now. This is the drug that Eisai has been developing in collaboration with Biogen. This is the New England Journal article that was released on the day that This was reviewed by the FDA, and it was given accelerated approval. It's a humanized monoclonal antibody. It binds to these protofibrils, which is a form of A beta protein in the brain. This trial, which was a phase 3 trial, was 1,800 patients over 18 months. They're infused about an hour. It lasts an hour, the infusion, and it's delivered twice a month. And there was that 27% change on a rating scale called the CDR sum of boxes at the end of 18 months. Now, I mentioned that there's these microhemorrhages or small bleeding and swelling in about 17 and 12% of patients, respectively, but most of those are asymptomatic. And again, we expect the FDA to review this by July 6th, and most people are expecting full clinical approval based on this study. Now, the auto-injector is under development. What an auto-injector is essentially is going to transform the treatment. It's going to move from intravenous in person every other week to a once-a-week auto-injector that someone does at home. And one of my clinical trial subjects and his partner the other day were telling me that this is just the easiest thing in the world, and I can't even believe that it's going to be effective. It seems so easy. So we'll see what happens. I mean, the jury's out about the efficacy and safety of the auto-injector. That's really under development.
So Brent, can I ask you, and I you know me, we could do this literally all day long. I cannot believe it is 4:15, because this is a topic I could do. I think everyone on this call could do all day. This is not enough time with you guys. I'm going to ask if you could, because I really want to make sure that people have a chance to ask questions and we get there. We save the 10 minutes at the end. I really would love it. And I do highly recommend. This was not an advertisement for Dr. Forester, but I can tell you how much it helped me. His book, I'd like for you to actually, everybody on this call needs to feel so hopeful. And this is part of what we're trying to do with this brain health series and all the work that we're doing, is that all the science piece of this is so critical that we are all working on. But actually, as we all know, 75 to 80% of our outcome is the epigenetics. It is not the genes we were handed. It is what we do every day really matters. How we lead our companies, how we treat our employees. The question I asked you is, you go to run a hospital and yet we're not giving anybody any sleep. We know that our food, our sleep, what we breathe, our meditation, these things all matter, and they actually have a far higher degree of impact than the actual genes and science. So we are working on all fronts, but can you please spend just the 5 minutes on your dancers program, kind of your acronyms of what you would have people do, other things we can take control of that lead to the epigenetics, which is the change in our genes over time based on how we live.
Sure thing, Sarah. So I give full credit to the acronym itself, to my colleague, Dr. Jim Ellison, who came up with the acronym, but essentially it takes decades of research and simplifies it into this strategies for healthy brain aging, disease management, activity, nutrition, cognitive stimulation, engagement with others, relaxation, and sleep. And I'll go over these briefly. We talked about the disease management already in the earlier part of this talk, but basically there's a whole host of medical issues that can cause cognitive problems prematurely. Sarah, you just mentioned sleep. We'll get into that in a minute, but we want to look for causes of cognitive decline that are treatable. Not that Alzheimer's isn't treatable. There's a lot we can do, but there's also a lot we can do to prevent the onset of dementia in the first place. And some of the areas that I think I highlighted on the left here, because these 5 areas are also all associated with cardiovascular disease and stroke. Everything that can cause heart disease can cause Alzheimer's disease. So aggressive management of hypertension, diabetes, obesity, getting people active, and reducing smoking. All of these factors, elevated cholesterol, I would probably throw in there as well. Medication management, disease management of treatable causes of cognitive decline to prevent the onset is critical. Of all of the areas in this acronym, I think the data is most strongly supportive of exercise. It's remarkable. In animal studies and human studies, look at all the beneficial effects that you can see here in terms of improvement in insulin sensitivity, better energy metabolism, which is one of the outcomes we're studying in one of our trials. Even promoting neurogenesis and mood elevation and reducing anxiety, which also should be on this slide. We also know that there's great data to support nutritional approaches that will reduce oxidative stress in the brain and promote healthy brain aging. So the Mediterranean diet is one diet. The MIND diet. There are a number of diets that really promote, focus on vegetables, green leafy vegetables, omega-3 fatty acids in fish, and de-emphasizing red meat and saturated fats. Some studies have been stopped early because the beneficial outcomes were so notable. Now, all of the, especially the last two things that I just mentioned, activity and nutrition, we all know this is true. This is not rocket science now. We know it's true. The hard thing is, how do you change behavior? Like, how do you actually get people to change their behavior? It's easy to prescribe a pill. It's hard to prescribe behavior change.
Brent, can I make one I'd love to have Dr. Palumbo actually chime in here for a moment, because two of the things you just mentioned, and it is so fundamental to some of the science and work that we're doing around inflammation. But when you think about eating foods that do not cause inflammation in your body, which are these diets. In fact, for people more interested in this topic, we did our whole first session on food in the brain. There's an entire hour Zoom on these diets and the foods and the impact, but also exercise in terms of your health and decreasing fat and inflammation. And we know in the science that we are all working on, going all the way back to not just focusing on the plaques and tangles, that the inflammation is causing cellular breakdown. Joe, can you just spend 1 or 2 minutes on that, since this is a real area of expertise of yours and the kind of science that we're working on in that front, because all these things play in together.
Well, certainly, the hypotheses are based on these kinds of observations around activity, around diet, that if activity can reduce inflammation and make insulin more effective and bring glucose into the body and helping cellular respiration, if diet can do some of those things, if there were pathways that were accessible pharmacologically, that would be very interesting, and it's certainly something that we're testing. So yes, these may turn out to be approachable pathways for pharmacology.
Brent, I'm sorry, go ahead with your.
No, it's fine. I'll just go through the last real quick because I want to make sure people can ask questions. But there's a lot of there's a huge market in these brain games, cognitive stimulation. Some of them are really fun and interesting. I think most importantly is that we know that cognitive reserve is an important concept, that lifetime education actually protects against a cognitive decline. We also know that greater cognitive activity has direct biological effects. Some of the programs that are out there demonstrate improvements in various cognitive domains. How they translate to real life in real world settings is less clear. But that is really an important part of this acronym. And then finally, well, not finally, but almost finally, engagement with others, social isolation. Our Surgeon General right now is making this his cause, is the isolation epidemic in our country. But this is a factor that's associated with health decline. We've known this for a very long time. And it's not just dementia risk, but it's also risk for other illnesses, including cancer. And social isolation may directly impact immune function and increase inflammation. So again, non-biological ways of actually having a biological effect in the brain. And then again, it helps in many ways, both biological ways as well as reducing anxiety and improving mood. Sleep is critical. Sarah, you mentioned this at the outset. I always wonder when I get up at 5 a.m. to either ride in a spin class or go for a run and make sure I get my exercise in, if it's worth the lack of sleep, like which is more powerful. I don't know the answer. I should probably do both and go to bed early, but I really haven't figured that one out yet. But the data on sleep is really remarkable as well. We know that sleep deprivation and sleep disorders do contribute to the deposition of amyloid plaque in the brain and also increase the risk for falls, cognitive decline, and pain. And then there's this book that Harvard put out at the medical school, to a guide to cognitive fitness, which is a multi-pronged approach integrating all of these concepts and can be really good. So I'm going to stop there and stop sharing my screen so we can just chat.
So we can chat. Well, let's two things we'll do. One, I love to hear the person actually ask the question. So dive right in. This is a conversation, but if you're in a spot where you can't ask it and would like to text it in the chat, I'm trying to make sure that we can that we can, see the chat. So you can also do that. But who has a first question for Dr. Palumbo or Dr. Forester or both?
I have a question. I'll go first, jump in. Dr. Forester, the one thing that I would really love to hear about and that I know that you have a huge impact on right now is the emerging generation of doctors and researchers that are coming through medical schools and things like that. And I remember talking to Dr. Palumbo about how unique your skill set is, and this very, like you said, brings together the geriatrics and the psychology. So from your sense, I'd love to know if there's some promise in in some of the young doctors that are coming through the ranks.
It's a great question, Allison, and it's one that I've been passionate about for my whole career. Right now in the United States, we're training 50 new people to become geriatric psychiatrists every year in the whole country. We're filling only half of our fellowship spots. And I think there are two real reasons for this. And for those of you in the world of business, if you want to come help join an organization that's really promoting interest in the field and trying to get people into the field, it's our American Association for Geriatric Psychiatry. I just finished up a 2-year stint as president, and a big area that we've worked on is training the next generation of specialists. But the two reasons why people are reluctant to go into the field are, number one, stigma and bias. And we call it ageism, people projecting their own feelings about aging. And why would I want to go work with that population? And again, therapeutic nihilism, and like they think about what can't be done as opposed to what can be done. And what's lacking is exposure to mentors. We know that medical schools and residencies that have mentors who do this work and bring trainees with them to see patients impact career decision-making. And so that is really critical. So we've set up these mentoring programs within our organization to bring medical students and residents to our national meeting to get people excited about our field and then follow them over time. What we're now doing is we're going into colleges. And frankly, I think we got to go back to high schools, because honestly, it's got to start early. If we happen to have a great experience with a grandparent, terrific, but that's random, And so for those people who loved hanging out with their grandparents, a lot of them want to go into this field. But if we don't have that exposure early, it's a problem. So that's one problem. The second problem is money. Medicare. Medicare is great in that it's a social safety net, but the reimbursement is not great. And the psychiatry reimbursements are poor compared to other medical reimbursements. So the actual average salary that someone makes after training for an extra year does not necessarily make up for that added year of being in training. But moreover, their ability to be compensated at competitive wages is problematic because of reimbursement from Medicare, which does not allow people to charge out-of-pocket payment, which, by the way, I'm not a fan of, but I think people go into child and into forensics because they can get paid a lot of money out of pocket. So there's a huge problem with ageism, and then the exposure early on, and then the financial reimbursement realities there in terms of the next generation. I think in terms of hope, more people today are going into psychiatry than ever before. It has become one of the top specialties of interest amongst medical students. So we have an opportunity to bring some of the younger folks going into psychiatry into our field. The other is that I think our ability to scale our expertise in creative ways using technology innovation is going to be really the promise of the future. We need to get nurses, nurse practitioners, social workers, general practitioners, every piece of the medical community, and frankly, the non-clinician workforce, to appreciate and how to manage older adults, specifically those with cognitive disorders. That's the only way we're going to be able to make a meaningful impact.
I think that was such
great.
an important,
Yeah,
such an important question. As you know, it's a huge initiative that we're working on with Social Impact Partners, is to engage the younger generation. And we have a whole youth leadership board and amazing innovators, but I think we have to talk to the younger people differently. We have to create different workplaces. We have to have different job descriptions, whether this is in the hospitals or in senior living or all of our enterprises, to really, make sure that they feel this is an innovative, engaging place where they're going to be rewarded, and really fun for people to get the word out to that younger group. We do actually have a business plan contest and Innovation Olympics starting in June. for Social Impact Partners, which already has some amazing business plans that have come in, including the young man who's down at the bottom of the screen, Morgan Mokada, who has a really, really interesting business he's starting in brain health and on our youth board. But are there any other questions we can, I don't know if we have an extra 5 minutes, Joe and Brent, because I know there's probably lots. And Dr. Osman has joined us in her beautiful blue sweatshirt. Do you have a question, Niley?
Yes. So what I'd like to know is, speaking about Medicare and the issues of reimbursement, it goes back to sort of the value that clinicians can bring in this area. And that translates into sort of the health economic and outcome research that needs to, I think, go into this area. So if you could give us an appreciation of how we can better research and communicate the impact that not only Alzheimer's has from an economic standpoint, but also MCI. Because with MCI, we believe by definition there can't be disability, but we do know that if patients aren't adequately, if it's not adequately addressed at that stage, the impact further on can be quite dramatic. So I just wanted to know your thoughts about that and how we can, how we should be approaching that.
Well, I mean, I'm not sure I have the answers, but I'll say a couple things, Dr. Osman, about this topic. One is the I think it's going to have to come from advocacy at the federal level in Congress. And if you look at what the Alzheimer's Association led over the past decade to increase funding for research in Alzheimer's, it's been staggering. When I started in this field, well, actually, when I started doing research in this field about 15 years ago, the NIA was funding about $500 million a year in federal research in Alzheimer's, and now it's $3.5 billion. It's a 7-fold increase in about 8 years because of advocacy and getting our Congress people to understand this epidemic. So I think that's really important. So that's one thing that's been highly successful. Advocacy at the federal level for congressional spending on funding for Alzheimer's research has really been a game changer. The second, I think, is in terms of the delivery of care. This is where I think we have to advocate and really get a hold of CMS and help them think about innovative funding mechanisms for dementia care. And actually, I think they're moving in this direction slowly. There was a meeting just Monday in DC around an alternative payment model, or an APM, through Medicare, through the CMMI innovation arm of Medicare, to do comprehensive dementia care funding. And they'll do a demonstration project potentially in the next year with about 10,000 Medicare recipients for comprehensive dementia care. We have that for renal disease. We need that for Alzheimer's disease.
That's a great point. Thank you so much.
So I know this group could keep going, but I'm going to honor everyone's incredibly busy schedule since I know you had an hour. And I just want to thank you both so much, and everyone who came. There are friends from all over, including France. Armel, thank you for coming. Armel has now moved to Cambridge. So we have runs a business that serves senior living and actually helps decrease isolation and loneliness and connecting families. So nice to see you, Armel. But this was really a wonderful session. We are going to have the recording, and things are really taking off with Social Impact Partners right now. And so stay tuned for some updates, but a lot of things are kicking off in June with Brain Health Month and a lot of engagement and innovation. So thank you guys again. And if there's any other big questions, I'll have people send it to me and we'll send it on, because I know we had short time there. Thank you so much. We'll talk to everybody soon.